Okay, and now for the last video in the series on high-risk antepartum. There are many, many conditions we could have covered. We didn't. We're going to talk about infectious disease in pregnancy and touch on hyperemesis gravidarum. Okay, so first, under infectious disease, we're going to talk about the torch infections. These are infections that mom contracts during pregnancy. And they usually affect baby more severely than they affect her. They are teratogenic. T stands for toxoplasmosis, O stands for other infections, R stands for rubella, C stands for cytomegalovirus, and H stands for herpes simplex virus. And we're going to cover the T, R, C, and H first, and then go back and kind of look at O for other infections. So, toxoplasmosis is a protozoal infection. Symptoms of illness are barely noticeable to the person who has them in adults and even young children, but it can cause intellectual disability in the baby if contracted prenatally. Okay, so this is one of the things that we ask on a prenatal questionnaire. Do you have a cat who changes the litter? Because it's found in cat litter or feces, it's also found in raw meat, and like this is something I would have never even thought to ask about unpasteurized goat's milk, but apparently it's a thing that a lot of people drink, or a certain type of demographic likes to engage in because it's more natural. But it can be dangerous. So we educate the patient to avoid sources of infection. There's really no effective treatment once she has it. Next, we have rubella in pregnancy. So prevention is the big thing because once mom is pregnant, we can't give her the MMR vaccine. It's contraindicated in pregnancy. So really, this is a place where ideally every single woman should go for preconception counseling, and we could catch it and give her the MMR vaccine. Some women don't seroconvert. They may have had the full series of vaccinations as children, but we are coming to a point in time where people who were unvaccinated as kids are now getting to be old enough to have kids themselves. And so they might be vulnerable to rubella. IgG is the titer that we draw to find out if a mom is immune to rubella. It's one of those first prenatal labs, if you remember. IgM tells us she has active disease, and it stays present for about a month after exposure. Symptoms in mom are mild. She might not even realize she's got German measles or rubella, but she gets a maculopapular rash similar to measles, mild. She gets some mild aches and pains, maybe a low-grade fever and swollen glands. The baby, on the other hand, especially if we're looking at a fetus under 20 weeks, and that first trimester is the worst time for exposure, faces deafness, blindness, intellectual disability, heart defects, and cerebral palsy. And newborns can shed the virus for months. So if they're born with active congenital rubella, we need to isolate them from other newborns so that they don't get the disease. And a mom who is rubella non-immune during her pregnancy who is not exposed should be offered the MMR vaccine before she goes home. And she should be counseled once she gets the vaccine not to get pregnant for, some books say 1 month, some books say 3 months. 3 months is safer. And then we have CMV, or cytomegalovirus infection. So CMV is actually fairly common, especially in young kids in daycare. The woman might not have any symptoms at all. If she does, they're like mild upper respiratory type things. But if she contracts this in the first 20 weeks of pregnancy, she risks, or the baby might suffer from IUGR. If you've watched the other videos, I've said this before, it stands for intrauterine growth retardation, IUGR, so small baby, okay? In fact, sometimes when we have a baby who is small for gestational age, they'll run like a CMV panel to see if the baby's been exposed in utero. Baby can get severe developmental delays. I have heard that CMV is one of the leading causes of intellectual disability. Hearing loss, visual impairment, and then there are some dental problems that are sort of unique to CMV infection. There is no effective treatment for CMV. Prevention is hand washing and avoiding large groups of small children, particularly daycares. And that's tough when you have other kids who are in daycare. It's tougher still if you teach early childhood education, but this should be part of our teaching to mom. And then we have the H is herpes simplex virus. And the signs and symptoms of herpes: painful lesions on the external or internal genitalia. They can also occur inside the mouth or in the rectum. Um, they're like fluid filled blisters or vesicles. Congenital infection can look like fever. Now, most of the time when newborns get sepsis, their temperature drops, but in herpes sepsis, the temperature goes up. They can suffer from jaundice. They can have seizures. They're usually really crappy feeders. About half of babies with congenital herpes virus will have those vesicles all over their bodies, which is extremely painful. And you just, hope that doesn't happen. Encephalopathy is possible from the seizures and the ensuing brain damage. Herpes hides in nerve ganglia, and a primary infection, like the first outbreak, is the most dangerous one in terms of maternal and neonatal risks. So fetal risks, we have. Excuse me for the background noise. It's not me. Miscarriage, that can occur in the first trimester. Low birth weight, sometimes preterm birth, if that happens neonatally. The congenital infection is the bigger worry. Management, we give antivirals. So there are a few different agents, but the one I've seen most commonly is valcyclovir or Valtrex, and that's given for suppression prior to birth so that there aren't any active lesions at the time of delivery. Mom can deliver vaginally if there's no active lesions. The newborn would be treated with acyclovir, um, and that would usually continue for a little period of time to prevent transmission. Um, Cesarean if there's an active outbreak, and that can become kind of sticky because the virus does hide in the nerve ganglia. Um, she's probably going to have a cesarean under general anesthesia because a spinal could be risky. And hold on one second. I'm going to pause the recording and add some things. Okay, so I'm back, and hold on one second. I'm going to get this up into a presentation screen so it's nice and big. All right, so other infections. There are many, many infections that a woman can get during pregnancy that might impact her prenatal course, but some of the big ones, gonorrhea and chlamydia, are sexually transmitted infections. The biggest risk for gonorrhea is neonatal blindness, and that's why we treat baby eyes with erythromycin ointment as a routine measure. Um, Whether or not we know that the woman has or suspect that she has gonorrhea, we just do it for all the babies unless the parents refuse. Chlamydia can also cause conjunctivitis and blindness, and it can cause a pneumonia. So GC and chlamydia, which in my population is pretty prevalent, are things that you would want to test for, and you would want to give that eye ointment right at delivery if you could. And also, you're going to want to report to the pediatrician so they know to look for that chlamydia-related pneumonia. GC and chlamydia tend to come together. They have some synergistic relationship. Also, there's UTIs are more common in pregnancy. We've talked about that, and pyelonephritis. They are a risk factor for preterm delivery, but pyelonephritis in particular can make a woman pretty miserable. If a woman gets recurrent UTIs and they kind of climb up the renal, through the ureters to the kidney, she can get a very high temperature of like 104.5. I mean, we typically see really, really high temperatures, and we see costovertebral angle tenderness. She's miserable. Body aches all over, chills. We want to treat that pretty aggressively, and then we want to maintain her on macrobid. We'll usually start with like IV antibiotics for a good 5 days, and then PO antibiotics, and then she'll go home on macrobid to prevent recurrence. Trichomoniasis and BV. Trichomoniasis is like a sexually transmitted infection, and BV is just, like I said, it's like a vaginal infection. It's not necessarily sexually transmitted, but they do impact things like preterm labor, preterm rupture of membranes, low birth weight. They are associated with those things. And then we have syphilis. Syphilis, we used to think that was eradicated. And recently, New Jersey reported a fourfold increase in the number of cases of syphilis. Those of you who were on C5 with me at Episcopal in the fall probably recall a couple of clients that had active syphilis infections. So it is on the rise. We do need to test for it. Babies can be born with congenital syphilis. It has severe neurological effects in the newborn. And so we would treat with penicillin. Zika virus. I haven't heard a lot about it lately. For a while, it was like a really big thing. We saw it coming from Central America and Florida and some parts of Cuba. Anybody who would come from any of those quote unquote Zika regions, what was happening, they were getting infected in pregnancy and their babies were born with anencephaly or microcephaly, defects of the brain if they were infected at a critical point in pregnancy. It does live in the partner's sperm for up to a year. When patients come in for admission where I work, we have to ask them if they've been to a Zika area. Although we did see like a number of cases for a little bit. It can be devastating to a woman of childbearing age. So those are the other infections. Next, we're going to move on to HIV. We kind of touched on that in the very first class when we talked about the patient that I had over winter break. People are living with HIV and not necessarily dying from it. They can consider pregnancy with good preconceptional counseling and management of their HIV. The goal of management here is a healthy mom who has a healthy functioning immune system and no vertical transmission to the fetus or newborn. So the CDC recommends that we routinely screen all women, and you will discover new cases of HIV in prenatal care. Maybe a woman didn't think to get tested. And we've had that happen recently a few times. Women who maybe came from other countries where rape was a weapon of war, and they are carrying the HIV virus, and they test positive for the very first time on their prenatal visit. HIV positive women should adhere to antiretroviral therapy. There are different regimes that are used for women who are pregnant that are where the benefit outweighs the risk, and the risk is relatively low. But they should adhere to it to prevent resistance. We're going to have increased surveillance for mother and fetus. We're going to look for any sign that mom's immune system isn't compensating. That means like an all-over physical assessment. And we're going to look to make sure that her fetus is doing well as well. We're going to look for growth, AFI. We're going to look for reassuring non-stress test. But we're going to, make sure that everything is going well with that. We're going to count mom's viral load, and we're going to look for her T cell count and make sure that her viral load is low and her immune factors are high. The mode of delivery is going to depend on that viral load. If she has fewer than 1,000 copies, she can have a cesarean. If she has 1,000 copies, if she has more than 1,000 copies, she must have a cesarean because there is less chance that the baby will be exposed to her blood. If she has fewer than 1,000 copies, you can try vaginal birth, but avoid any invasive procedures like internal monitoring. Vacuum extraction would be another one where you're creating portals for infection in the newborn. And when we talk about labor, it'll make more sense. Internal monitoring means you screw a little electrode into the baby's scalp. Vacuum extractions, a lot of times if you assess a newborn who's had a vacuum extraction, you'll see little abraded areas on their scalp. So we want to try and prevent that method of transmission. You always want to prophylax these moms with zidovudine or AZT in labor. It crosses the placenta rapidly. And even if mom has had no treatment all through pregnancy, we can reduce the chances of transmission to the newborn to be like less than 2%. In the majority of cases where babies are born with HIV, the mode of transmission was delivery. It didn't happen prenatally. It didn't happen with breastfeeding. It can happen those ways, but most of the time it happens in labor and delivery, in birth. We recommend formula feeding, and the newborn will be followed with AZT. And the last topic for this video is group beta strep, or GBS. GBS is not technically truly an infection. It is normal flora for about 1 in 5 women. But because newborns are immunocompromised, a few of them who are exposed during delivery will have severe sepsis. And what that looks like is poor feeding, unstable vital signs, their temperature will go down. We'll see changes in their lab values, they're below. What we do about this is, we don't get too crazy, but mom comes in labor or she's ruptured. her water's broken, and we give her penicillin every 4 hours while she's in labor. A typical dosing schedule, you don't have to write this down. It might become a math problem, but it wouldn't be a test question. 5 million units initially, so bolus her and do the best you can to get all of that GBS out of there. And then every 4 hours, you're going to maintain a 2.5 million unit dose. Penicillin comes in wacky doses. It's not milligrams, it's units, and there's huge numbers. But 5 million to start and 2.5 million every 4 hours thereafter until she delivers. If mom comes in and she's laboring so fast we can't get 4 hours of penicillin in her, or she's allergic to penicillin and everything else that works on GBS, there's not many things that they'll accept as adequate treatment. You can put it into a sepsis calculator, which is really fancy for an undergrad student. Um, if you were, orienting to labor and delivery, we would teach you how to do that. But basically, you're going to monitor the newborn for decreased temperature, poor feeding, lethargy. If they look funny, if their color changes, anything, you're going to report that to the pediatrician immediately and have them worked up for sepsis. Now, some babies will require some lab work, and we'll draw a CBC, usually do that through a heel stick, and you'll see what's called a shift to the left. Now, you may have heard this term in GMP, other GMP courses. What it basically means, don't worry about where the term came from or why it's on the left. It basically means we have a lot of immature white blood cells that the body's creating in response to an infection. So the body's trying to mount a response, and we see a lot of brand new baby white blood cells trying to come to the rescue. So that's why we see that shift to the left. CRP is C-reactive protein. It's a marker for inflammation, and that will be elevated. We might draw blood cultures. It used to be our protocol where I worked to draw blood cultures on any baby who didn't get adequately treated, and they may show growth of that group beta strep. So that's GBS. And then our last topic is hyperemesis gravidarum. Aren't you lucky? What it means, hyperemesis means a lot of puking when you're pregnant. Excessive vomiting during pregnancy. It interferes with nutrition. Obviously, if you can't hold food down, you're not getting any nutrition, and can cause serious fluid and electrolyte imbalances. And that's where you should mostly pay your attention. So, management. Replace the fluids and electrolytes, especially potassium. These people get a lot of K riders. When you vomit, you lose potassium and sodium. Potassium rules cardiac function. That's one of its functions. So if we don't have potassium, we see changes in our EKG, and you can get serious cardiac involvement. We're going to keep mom NPO for a couple days until the vomiting stops, and then we can advance her slowly through clear liquids, and then maybe to a bland diet as tolerated. It's a pretty miserable experience. I have had patients who say that they would never have gotten pregnant if they knew it was going to be like this. And I had actually one patient ask a provider for a termination of pregnancy at like 14 weeks because she thought the vomiting would stop, and it did not. We can administer antiemetics, Zofran, Reglan, Phenergan, Diclegis. Diclegis is the only one the FDA approved specifically for this use, but you might see any of these other ones used. Diclegis is an antiemetic combined with vitamin B6, by the way. But I have seen these other agents used pretty commonly. The Zofran, Reglan, Phenergan. It's kind of whatever works. It's beyond queasies at this point. This is a serious, she's losing fluids, she's losing electrolytes. We may have to administer TPN, and you might have to get a central line. And they don't like to do central lines on pregnant girls because the risk of eclampsia is higher in a patient who's immunocompromised, but you do what you have to do. Measure INO. Most of the time, what you're going to see, these people have really flat veins, crappy veins. So, of course, you're trying to start an IV, and there's nothing there. And you're going to see their urine is like super concentrated. It's almost like iced tea in the hat or the container. And if they've got a Foley, it'll look the same way. So we're going to measure their intake and their output. And the output's going to include their emesis, their vomit, to have some idea of what their fluid and hydration status is. And we're going to provide a lot of emotional support because this is hard. Somebody might be really desirous of a child, and they plan this pregnancy, and then they get stuck with this, and they feel pretty miserable. And it does tend to recur in subsequent pregnancies. So that's Hyperemesis gravidarum. And that's it for all of our videos. Thanks. If you have any questions, you know where to find me. Most of you have my cell number. I am not posting that on YouTube, God knows. But you have my email. Thank you for listening, as always, and I can't wait to see you again.